Welcome to Striving for Consensus, Current and Future Management of Immune Thrombocytopenia. This is medical oncologist Dr. Neil Love. For this program, I met with Drs. Hanny Al-Samkari from Massachusetts General Hospital, James Bussel from Weill Cornell School of Medicine, and Nichola Cooper from the Imperial College of London to discuss the clinical manifestations and management of ITP. To begin, I asked the investigators to comment on key ITP issues for clinicians in practice.
I think there are a lot of things in a lot of questions that come up with ITP in clinical practice. The first, I would say, we can think about both the management standpoint as well as the diagnostic standpoint. From the management standpoint, it's often, what do we do after first line? What is recommended? How does an expert decide what therapeutic to choose for the patient? And we're in a place now in ITP where we have, in the United States, 4 FDA-approved drugs, as well as another drug that has high-level evidence. So we have 3 thrombopoietin receptor agonists, we have fostamatinib, a spleen tyrosine kinase inhibitor, and we have rituximab, obviously an old standby. And then obviously on top of that, right, we have splenectomy too. So, there are a lot of different options and sometimes, practitioners out in general practice, ask how do we choose, between all of these and how do we choose between the various thrombopoietin receptor agonists if we choose to treat with a thrombopoietin receptor agonist? People will often ask if the patient doesn't respond to a thrombopoietin receptor agonist, should we try another thrombopoietin receptor agonist? If they don't respond to the second one, could we try a third one? It's a common question is, when should we think about combination therapy in patients that have more difficult to treat disease? I would say from the diagnostic standpoint, people often ask, when do we need to do a bone marrow biopsy? I have a 62-year-old person that came in, they have a platelet count of, 45,000. Maybe their MCV is a little bit, tiny bit elevated, 98, 99, close to the upper limit of normal, and they have a very mild anemia. Is this somebody who needs to get a bone marrow biopsy, or, is it close enough to ITP that we think this person can be diagnosed as ITP? How do we approach that? So there are a lot of, sort of border cases in terms of diagnosis. And of course, we don't have any, gold standard diagnostic tests that are widely available for this disease. And so a lot of it comes into our clinical judgment. So I think those are questions I get asked a lot.
So, Nichola, I'll ask you to maybe add on to that, and we can keep these things in mind as you present your cases and as we talk to try to get into it. Any thing you want to add to that, Nichola?
Yeah, sure. So I think a few things. I think that often people don't completely know how to manage thrombopoietin receptor agonists. So if the platelet count goes high, they might stop it altogether and then the platelet count crashes. We see that a lot, or even starting at really low doses. So I don't think any of us start romoplostim at 1 micrograms per kilogram. I tend to go straight into 1 vial. And then stopping TPOs if they're having a really good response. So, and I think if you just follow the SPC, I don't think it's very hard to manage patients. Second thing I think I see a lot is people switching treatment too quickly, not really giving a treatment a chance to work. So by the time they get to me, they may have seen 4 or 5 treatments already, and actually then have to try and unpick that and see what they respond to. And the third thing, I think certainly in the UK, we're not using a lot of rituximab now. And actually that's a really good treatment for ITP. So we suddenly find they've referred them on to me because they've got refractory disease, but actually they've never had some of the immunosuppression. So I think we have gone away from immunosuppression a bit too much, I think, and there's plenty of very safe, very easy to manage immunosuppressions.
Curious, Nichola, do you think that there are patients who are being treated and who maybe wouldn't be treated by an investigator or a person with a lot more experience?
Yeah, completely. I think we're in an NHS and people go to their local hospitals, and I think within a big, busy hematology department, often people don't have the time to be able to spend with people with ITP, which is kind of benign disorder. So it's just busy. So people don't always know or don't get the chance to be as experienced.
Yeah, I was just curious whether you think people treat just because of a platelet count, they don't have bleeding, and really the
That
platelet
is
count's not
true.
low enough.
Yeah, that is very true. And I think that, a lot of the Irish stuff that we all worked on showed how anxious patients are about their platelet count. And some of that anxiety probably comes from us as clinicians, and actually trying to get away from just the platelet count, I think, is really important.
Jim, anything you want to add to this?
So I think diagnosis is a really big issue. I mean, I don't mean, oh, yeah, well, I mean, Hanny, you work in my mind in a very privileged situation where you have a lot of hematologists in the MGH, umbrella who will then ask you about patients that are a little tricky. But in general, I think you have a great group and that helps you to do really well with them. I see it much more as, we don't have a good diagnostic test. And I think many of the people who are seeing the patients, like you said, Neil, are focused on things that they see as higher risk and more important, so that they don't have really the time to get into the weeds on how do they select things or how do they decide for sure the patient has ITP. So I think at least, there's one study from an experienced investigator group that had over 17% misdiagnosed patients. I think in common practice, it's probably even higher than that. And I think most people, it's so complicated. I think most of the people in general practice don't really know how to manage it very well and, how to pick out all the subtleties. I think some of that is, quote, our fault, meaning the experts, because we haven't laid out a clear algorithm for diagnosis. And at least in my setting, a lot of people will go to the emergency room and they'll get a platelet transfusion. I think 25% of U.S. patients get platelet transfusions. And that's just, to me, a CYA maneuver. Somebody doesn't want to come in at 10 or 11 at night, and the ER manages them. And I think Donnie Arnold's work has highlighted that also. So I think there's a lot of subtleties there. As far as second-line agents, I think going down, if you will, or using less rituximab, which I agree with Nichola, is not necessarily fully appropriate.
Totally.
I think TPO agents get used almost invariably, and people don't really, as Nichola highlighted very nicely, know how to use them that well. So if they use them and it works, it's fine. Big problem I've seen is with L-Trombopag when they're not really told about the diet. Yeah. So these are just some of a number of things that have come up, and I'm sure if you kept us at it, we could come up with many more.
No, I'm really interested to hear the clinical pearls you have about how you deal with the issue of diet. Nichola, you had a comment or thought?
No, I was just agreeing. Actually, I think that rituximab was a really good drug, actually, and for some people it's great. And we're going straight to TPOs, and everyone's kind of forgotten that this is often, not always, an autoimmune disease. And I think that some of that's related to education, who's sponsoring education sessions, I think. But, which is why these kind of things are really important.
I was wondering, do you think some of it might be related to COVID and concerns about CD20?
Yeah, absolutely. People, definitely.
Yeah.
When I started, we thought people overused rituximab because the general hem-onc that you're referring to was very familiar with its use. So they used it all the time, seemingly as the first line agent. And I think COVID really affected a huge switch.
I totally agree. I mean, it's vitamin R, right? And it's something that everybody's comfortable with, particularly in practice. You're using it for, low-grade lymphoid malignancies as a single agent, using it in combination for, higher grade lymphoid malignancies and so on. So, I think there is still a decent amount of use of rituximab in the community in the United States, but it definitely has dropped off. And during COVID, for us, it dropped off and it's not recovered in our in our academic practice, it really hasn't recovered. But, we have to remember that it's an option, that it's there.
All right. Well, that was great to kind of get some thoughts out there, and we'll pick up on that as we go through this session. We're going to move on now and let Hanny do his presentation. Hanny, take it away.
To start things off, let's talk about clinical manifestations and initial management of ITP. So I have a few cases I'd like to share and get everyone's thoughts on. A 56-year-old man with a past medical history of ulcerative colitis presents to the ED with diffuse petechiae of the upper and lower extremities. He awoke this morning to the taste of iron in his mouth and saw large blood blisters on his oral mucosa. On initial labs, his platelet count is 5,000. The remainder of his CBC is unremarkable. He endorses recovering from a head cold about 3 weeks ago. So this is a typical case, a typical presenting case of ITP, a very classic, read the textbook type of case. The patient has an autoimmune history with ulcerative colitis in his past medical history. He had a viral illness, and now 3 weeks later, he presents with a very low platelet count and bleeding, very consistent and very classic for primary ITP, for ITP, okay? So primary ITP is isolated thrombocytopenia that's not associated with another disorder. This forms the majority of our cases of ITP. Secondary ITP is ITP that's associated with 4 general major categories of disorder, including infection, immunodeficiency, autoimmune disorders, lymphoproliferative disorders, most classically CLL. You might say, well, wait a minute, Hanny, we just talked about this patient had ulcerative colitis. Does that mean he has secondary ITP? There actually is a lot of mixed messaging on what qualifies as secondary ITP, and this is something that's actually being addressed at the standardization level. But for right now, we primarily think of patients with lupus and really classic collagen vascular disorders, and also antiphospholipid antibody syndrome. Those patients have secondary ITP related to their autoimmunity. Somebody with type 1 diabetes, ulcerative colitis, Hashimoto thyroiditis, those patients have primary ITP that, is just there in addition to their underlying autoimmune disease. We also can't forget drug-induced immune thrombocytopenia, which obviously is very classic with many of our inpatient antibiotics that we reach for all the time, drugs like vancomycin, drugs like cefepime and ceftriaxone, as well as a number of other agents that are related.
I know, Hanny, that you outlined secondary ITP just the way you described it, but I find it hard not to imagine that somebody who has ulcerative colitis and ITP doesn't have, let's say, some predisposition that's leading to both. And also, just for the record, I don't know if it would matter. You didn't say in the presentation if they're on medication, how active it is, et cetera.
Yeah, and I think, Jim, your point is a really good one. Autoimmunity begets autoimmunity. We know that there are, underlying HLA alleles that predispose to many of these autoimmune diseases, often multiple disorders for a single allele. We know that autoimmunity is a very obviously complex thing, and I think this patient likely is predisposed to both the ulcerative colitis and the ITP, just from a purely categorization standpoint, because we classify and we categorize, right? There's a lot of confusion as to what counts as primary and what counts as secondary. And just the way that we do it, as you know right now, is that the patients with systemic collagen vascular diseases like lupus, those tend to be, more in the line of secondary ITP when the patient has ITP, particularly systemic lupus. And other autoimmune diseases, we classify the ITP as primary, despite the fact that the autoimmune disease is obviously a part of the patient's history. And almost certainly they have a factor that contributes to both, risk factor that contributes to both. Other thoughts on primary versus secondary ITP?
So I guess the point is that it's secondary to something that we don't yet know. So both the inflammatory bowel disease and the ITP is secondary to a something.
Yes.
Which is where I think the semantics, confuses us.
I agree. And one of the aspects of this that are important to mention, right, and why we bring it up, certain clinical trials will only allow patients that have primary ITP to enroll. So how it's defined actually matters. Certain drugs, right, were developed specifically in the setting of primary ITP. We use them all the time in secondary ITP too. But, there is this distinction. And so sometimes it's a distinction without a difference, but sometimes it does matter. And if you're talking about a disease like CLL or like lupus or one of these viruses, for example, treating the underlying disease can treat the ITP, can cause the ITP to improve or remit, right? So those things that's a very important aspect of the distinction as well. All right, so when we talk about the phases of ITP, also known as ITP chronicity, we will say a patient has newly diagnosed ITP if their ITP duration has been less than 3 months. We'll say it's persistent if it's 3 to 12 months, and we'll say it's chronic if it's greater than 12 months or greater than a year. Now, does this really matter in terms of what medications the patient is likely to respond to? No, it does not. Even though there are medications that are approved in the setting of quote unquote chronic ITP, we recognize that, from the perspective of treating the patient, this is largely irrelevant with the one exception of splenectomy. We try to avoid reaching for splenectomy in the first year and only reach for that after the first year of disease because we recognize there's a real remission rate in that first year, and we want to give people that opportunity before they develop chronic disease. Now, sometimes, unfortunately, right, the phases of disease can be used as a little bit of a bludgeon by payers to say they don't want to cover something, they don't want to pay for something. That's unfortunate. There's more data that's coming for certain newer drugs that are currently only approved in the chronic space to try to alleviate that issue, but it's something that certainly does still come up. We get asked a lot about platelet thresholds. How low does my platelet threshold have to be before the patient is really at risk for bleeding? How low does it have to be before the patient really needs to be treated? There's a lot of variability here, right? Is the patient on antithrombotic therapy? Is the patient an older adult, or are they a younger person? Is the patient very highly active in contact sports, right? There's a lot of different things that really factor into when we select a platelet threshold, what that should be for a certain patient, and we say we want to treat above. And obviously we have to consider other aspects, toxicity of therapy, the fact whether or not the patient is bleeding at that platelet count. There are a lot of aspects that matter here. But as a general statement, if you take a look at patients who are non-anticoagulated, not on antithrombotic therapy, not older adults, typically, most patients don't really bleed at all if their platelet count is above 50, related to their ITP, right? Not at increased risk of bleeding, I should say. Their bleeding risk between 20 and 50 is maybe increased with trauma or surgery. Below 20, they clearly have an increased risk of spontaneous bleeding, and definitely below 10. So those are some thresholds that we will sometimes talk about. Jim, do you have any thoughts on this?
I just wanted to say that you very elegantly and carefully went through a lot of this. And I'm sure if you said, well, if I had had more time, I could have said even more, like, can the patient come to clinic? All these other things. But that's the kind of subtlety that I think is very hard for somebody in practice to manage. I mean, we're not even talking about treatments here. Specific treatments. So I'm just highlighting that you did a really elegant job there, and that's a very difficult area. And I think, Nikki, you would agree with that also, but you might have different thoughts about it.
Yeah, and I also think that it depends what part of their ITP they're in. So if they're newly diagnosed or persistent, you don't know if they're bleeders or not. You don't know if there's something going on in their head that might suddenly explode into an intracranial hemorrhage. So, most bleeds occur early, and that's very different from a person who's had ITP for 10, 20 years. is refractory to most things, and everything they have makes them feel worse. So if that person's always got a platelet count around 5 and they've never bled before, it's a very different person from a new person who's just presented to you. Or another case we've had recently where the romoplastin was stopped inappropriately and the patient dropped to 0. That's very different from a patient who's got a platelet count of 2 and they don't respond to treatment. So it is a lot of other things that we think about rather than just immediately reaching to admit the patient, immediately reaching to give them IVIG, immediately giving them lots of steroids. So we do make different decisions. And I think I became very aware of that when I've got a new consultant working with me who I think she realized that I was making different decisions on the same platelet count in different patients, and which we do if you're experienced enough, I think. And I think that, other people who don't look after a lot of ITP patients get terrified by low platelet counts. So experience helps you to manage that. And I think guidelines are important for people who don't have a lot of experience, but there's lots of nuances that we are all picking up all the time, I think.
Absolutely.
Hanny, can I just add a brief comment? Also, at least for me, you meet a new patient for the first time and they have a low count, you have to caution them, well, they could have a bleed in the brain.
Of course.
Then they turn around the next day or two, their count's a little better, and you say, oh, you're fine. You want to go on vacation to, Mexico, it's all good, and then I think that's a very schizophrenic thing that makes it hard for them in the beginning too.
Yeah. No, I agree. It's good to know how patients bleeding phenotype really presents.
Yeah.
As Nikki pointed out, sometimes you can have a single digit platelet count. The patient never bleeds. Every time we're treating the patient, it's just treating a number. Some of these patients have enormous platelets, very large platelets that are missed by the automated counters.
Yeah.
Their overall platelet mass, so to speak, is clearly higher than the platelet count measured on the CBC would suggest. And many times, these patients have they're very young, very active platelets, so to speak.
And the other thing, just back to what you said, Jim, is like kind of, you tell people to stop doing things and you forget to tell them to start doing things again. There's another thing, so they haven't been paintballing for 20 years or something, so the things you stop them from doing at the very beginning, you need to remember to tell them it's okay now, or the dentist say, oh, this person's got a platelet, an ITP, should we worry about their platelet count of 100? It's like, no, so yeah.
Indeed.
I also just want to caution about one thing. There's a tendency, at least I thought I heard this from you. Hey, if they've had a platelet count that's low for a long time, they're not on treatment, they're not bleeding, they're probably okay, you can leave them alone. In principle, yes, but in practice, I've had patients who had their first major bleed 5 or more years on.
Yeah.
And, have had intracranial hemorrhages or major vaginal or GI bleeds. So I'm not quite as comfortable as the way you described it. I'm not trying to disagree.
No, I guess perhaps I'm just sort of thinking of the very refractory patient who would end up in hospital the whole time if you always admitted everyone with a low platelet count. So I guess that's what I guess more related to what do you do for those patients is a different decision sometimes, even though they're still at risk. You can't keep someone in hospital all of their lives. So I guess those are the sort of things to think about.
I was just going to ask a practical question in terms of, it sounds simple, but what you define as bleeding or bleeding that's of a concern. And Hanny, what I'm really curious about is petechiae and bruising on the skin. In what situations do you look at that and go, oh, no big deal? In other situations, you're concerned about it?
It's a great question. I mean, if somebody is developing petechiae, if they are bruising, and their platelet count is low, or even if it's not terribly low, but they have other risk factors for bleeding, then I take that seriously. And I don't want the person to be passively bleeding. There's a lot of lore about bleeding in ITP. People will sometimes say, oh, if they have blood blisters in their mouth, they're at a higher risk of bleeding in the brain. That comes from an extremely old letter to the New England Journal of Medicine that was a small case series. It was a brief observation. We don't actually know that to be true.
I beg to disagree.
Really?
Keep talking, but I would disagree.
Fair enough. So I think that in general, we don't want people to be passively bleeding. If someone has that, to me, it's an indication to raise their platelet count. Now, I'm not going to, I'm not going to necessarily admit every single patient to the hospital that happens to have some petechiae. If they're a chronic patient, I know what they respond to. They understand their disease. They know what to do if things get worse. I'll start that patient sometimes on outpatient therapy, right, without sending them into the hospital. But if it's somebody who I don't know how things will look, I don't know how things will evolve, I don't have as much experience with that patient, then I'm more apt to do this under controlled circumstances and treat them in the hospital. Jim, why do you disagree with me on blood blisters? Where's your evidence?
First, in the bleeding scale we published in 2007, we had more blood blisters in the patients who had an ICH. More specifically, or better evidence, I think, comes from the Japanese intracranial hemorrhage study, where they looked at the platelet counts and the manifestations. Maybe I have it wrong, but I thought they had oral bleeding. But could I, since this is controversial, I mean, I'm not trying to pretend, I have the answer. I just don't think it's as black and white. I do think it's really important to mention that I think menstrual bleeding in women with ITP is hugely underconsidered, and most people don't even know how to ask about it. And
totally agree with that, and particularly for young girls as well. They don't mention it. They say it's all fine, and we have to ask them. I completely agree with you, Jim.
And I don't think it's as simple as saying, let's give them tranexamic acid either, necessarily.
Yeah, I agree.
What do you ask them, or what are the specific things that you're looking for when you get a menstrual history?
I would try to ask how many days, how heavy is it, how often do you have to change pads, do you saturate your pad? If you really wanted to try to do it, there's something called the PBAC that you can use and show them, and that way they can give you some kind of semi-quantitative estimate of how much they're bleeding. But you also would need to check their iron, and they would typically be low in iron also. It's not as simple as it could be in my mind, but Hanny or Nichola, you might feel differently.
Yeah, I think flooding as well in the middle of the night, how many times you're getting up in the middle of the night. I think that's quite a good indication, because that gives you more understanding of what that impact is, I think. How many packs of pads you're going through, kind of just, because I think one of our teenagers is like, oh, yeah, I get through a pack a day. I was like, well, you shouldn't be getting through a pack a day, but she didn't know that. So, just kind of, you really have to get down to the detail. They're changing the pads every hour or something like that. You really do have to ask the proper detail of it, I think.
I totally agree. You can't just say, are your periods heavy?
No, they're going to
say yes or no, right? That's not good enough.
Yeah, totally.
All right. So let's get back to our case here. We have case 1, part 2. A diagnosis of ITP in this patient is made. If questioned beyond bleeding symptoms, what is the symptom the patient is most likely to endorse? Depression, anxiety, headache, fatigue, or insomnia? So I ask this question to highlight the non-bleeding manifestations of ITP, which are very important and which are often missed or glossed over in clinical practice. So we have some very nice data, actually directly from Nikki, who's right with us right here, in the IWISH study, which was a really landmark health-related quality of life impact of ITP on life study that looked at over 1,500 patients and almost 500 physicians globally. And this study really, showed us the impacts of many of these non-bleeding manifestations. And fatigue at diagnosis is not quite as common as petechiae or bruising, but it's pretty close. And certainly it's more patients reported it as severe. Then we see some of these other symptoms that a lot of these are bleeding related, but there are things like depression, for example, on here, and anxiety around their unstable platelet count. When we look after diagnosis, we see fatigue really comes out on top. This is really something that is often a chronic problem for these patients. We don't fully understand all of the reasons why this is. We suspect there might be an underlying inflammatory cause leading to this fatigue, as a result of the autoimmune process. Certainly, patients can develop iron deficiency that can be missed. When we treat with L-Trombopag, which is an iron chelator, when we miss heavy menstrual bleeding, right? There's a lot of things that come to it there. And then, right, the psychiatric comorbidity, the anxiety and the depressed mood can contribute to this as well. So we have to remember our non-bleeding manifestations. Sometimes we get asked, does the fatigue correlate with the platelet count? As it turns out, and this graph, again, came from an abstract presented by my colleague Jim here, this question is, a really good one, but from the perspective of from an inter-patient perspective, between patients, not so well. It doesn't really correlate. Intra-patient, however, it may correlate very well. So a patient may know that their platelet count is low on the basis of the way they feel before they have any petechiae or bleeding symptoms.
What's your understanding of why fatigue occurs?
Oh, I had mentioned that, Jim. I said we don't fully understand.
Oh, sorry.
It's okay.
Well, you said fully, so I thought, whoa, he's on to something.
Well, I mean, there are things that, we have the hypothesis of inflammation from the disease, and then there are things that certainly contribute to fatigue, right? Iron deficiency, oftentimes non-anemic iron deficiency, right? That's the most insidious kind. People who don't have frank anemia, often their iron studies never get checked, and those patients complain of fatigue. So we have to remember that. Right. And then and these patients with ITP, as we said, certainly menstruating women can develop increased menstrual bleeding, and that can cause iron deficiency, as well as the iron chelating effects of some of our drugs, like L-Trombopag, for example, can do this as well. But then on top of that, right, depression makes people feel fatigued. And so it's important to ask about those things. There are things that we can do something about, even if we can't necessarily tackle the underlying fatigue from the disease itself. So, I think it's really critical to highlight the risk of thromboembolism in ITP. The risk of thromboembolism in ITP is elevated at least tenfold and possibly more over the general population. This is a bleeding disorder that also causes an increased thromboembolic risk, which is obviously unfortunate and a challenging situation that we find ourselves in when our patients with ITP do develop thromboembolism. When we look back at the IWISH study that I showed previously, the thrombosis piece, I have a red arrow pointing here because it's not very common, but when it happens, it's the most severe symptom that the patients have, report on average, right? So it's a big deal. And, the median time in a large cohort study to first thrombosis was about 2 years from diagnosis, age, presence of secondary ITP, the number of lines of therapy, thrombosis risk factors that we consider for the general patient population, and thrombopoietin receptor agonist therapy were independently associated with thrombosis. And 96% of patients developing thrombosis had good disease control prior to that thrombosis diagnosis, and they received and tolerated antithrombotic therapy well. So I want to remind everyone that just because a patient is thrombocytopenic doesn't mean they don't need anticoagulation. It doesn't mean that we can't give them anticoagulation. We can treat their disease. We can raise their platelet count to an acceptable level, and we can anticoagulate them. And we really should, because these patients are at risk for bad post-phlebitic syndrome just like anyone is. IVC filters should be used sparingly, I would say. Jim, Nikki, any comments from you on that?
Very much so. I don't like IVC filters at all. At all.
Yeah. All right. So if we talk about other risks in ITP that have been highlighted, it appears as though, based on some epidemiologic data, that there is an increased risk for hematologic malignancies in ITP. Also a higher risk for gastrointestinal and skin cancers. In a recent large registry study, the hazard ratio for any cancer was 1.37. And this was really moved by a hazard ratio for lymphoma. And again, right, this is an immune dysregulation, and we use immunosuppressive therapies to treat it. So we can imagine why there would be an increased risk of lymphoma. There was also recognized an increased risk of myeloid leukemia, which probably, right, is congenital thrombocytopenia with risk for myeloid malignancy that has been misdiagnosed as ITP, at least in some cases. Splenectomy did not appear to modify the risk of hematologic malignancy in these patients. And in patients with thrombocytopenia who don't quite meet the threshold for ITP, we have looked at this, and these patients with platelet counts between 100 and 150,000, they also seem to have a heightened risk for hematologic malignancy as well as autoimmune disease and developing ITP, eventually progressing to ITP. This is from the study that was published that looked at, again, this risk of hematologic malignancy in patients with this entity called persistent isolated mild thrombocytopenia. This is a platelet count between 100 and 149,000. I get asked a lot, oh, my patient has mild thrombocytopenia. Is there any risk for that patient? Do I need to do anything? Mm-hmm. We don't know the answer to that, but evidence does suggest that there is an increased risk of hematologic malignancy and progression to ITP in these patients. And for the former, right, there's probably a significant component of congenital thrombocytopenic patients in this group of patients that leads to that heightened risk.
Is the heightened risk age independent? Meaning, is this mostly for older people or it's for anybody who's been followed? So if you started at 20, it could be at 40.
That's a great question. It is somewhat age dependent, but not entirely age dependent. So the earlier you develop the thrombocytopenia, the more likely you are to eventually develop over the course of your life to developing a problem. So it's worse to have it at 30 than at 60. But it's certainly, if you're older, you have a higher risk just overall of developing any of these complications as well, both ITP and hematologic malignancies. All right. So going back to the case, which of the following diagnostic tests is indicated at diagnosis in this patient? Bone marrow biopsy, direct glycoprotein-specific platelet autoantibody testing, hepatitis C serology, antiphospholipid antibodies, or a direct antiglobulin test. Right. And so, this highlights our initial workup, our initial ITP workup. And in this case, there is a right answer, and it's C, hepatitis C serology. We want to do this in patients presenting with newly diagnosed ITP along with HIV and some other testing. I like to call ITP a diagnosis of recognition. It's one of those illness scripts that we recognize when a patient comes in. And when patients meet all of those criteria in that illness script, we kind of say, okay, this really looks like an ITP patient. We shouldn't put our diagnostic blinders on, but that's what I say, a diagnosis of recognition rather than a diagnosis of exclusion. Many of these patients, if not most, right, present asymptomatically. They have a platelet count that's measured by a CBC, gotten for other reasons, and their platelet count is persistently less than 100,000. They're not necessarily in the emergency room, bleeding. And there's recommended diagnostic evaluations from both the American Society of Hematology guidelines and the International Consensus guidelines, which are two different guidelines for ITP. So this is an example of the diagnostic recommendations presented by the International Consensus guidelines. So a lot of this is standard, right? Patient history, physical exam. We take a family history because we want to make sure that there isn't a congenital thrombocytopenia that we're misdiagnosing as ITP or not considering the possibility that it could be a congenital thrombocytopenia. We get our typical blood counts, peripheral blood film, quantitative immunoglobulin measurements, HIV, hepatitis C, hepatitis B testing, and understand what the patient's blood group is, which can be helpful sometimes with initial therapy selection in rare circumstances, right, if we're thinking about use of anti-RHD immunoglobulin. There's a whole list of tests of potential utility. which I think, it's reasonable to think about some of these things in general practice. But we're primarily, these are not things that are integrated into everybody's workup. So if the patient, for example, has a concomitant anemia, good idea to get a direct antiglobulin test to see if they might have Evans syndrome and other hemolysis labs. If the patient has, a significant collagen vascular disorder phenotype, right? Antinuclear antibodies and other autoantibodies can be helpful to look for a secondary cause, like lupus, or to see if there's an undiagnosed other autoimmune problem. Certainly, pregnancy tests in women of childbearing potential is almost never a bad idea when we're trying to figure out what's going on and how to treat the patient. And then there's tests of proven or uncertain benefit. We don't get bleeding times anymore. You don't routinely get serum complement levels, things like this. At certain ITP centers, at my center, right, I get thrombopoietin levels, I get platelet autoantibodies, but that's not a typical thing that we do in clinical practice, and that's not a thing that people should take away from this presentation that they need to be doing. So we really are not perfect. We're not perfect at anything, but we're certainly not perfect at clinically diagnosing ITP. So in the McMaster ITP registry, McMaster is a university in Canada with a very, very strong expertise in ITP and thrombosis and hemostasis. These are expert clinicians diagnosing ITP. They had a miss rate of about 12%. And then they ultimately they diagnosed 12% of patients with ITP who didn't have it, and they missed 3% of the ITPs that were diagnosed as other things. And then in another study looking at pediatric patients, about 14% were missed. So, you could recognize that miss rate even in expert hands of about an eighth of patients to a sixth of patients. So we have to recognize that because we don't have a gold standard diagnostic test for this disease.
Hanny, just to be fair, the miss rate, if I understood your presentation correctly, you think it's mostly people who were said to have ITP who don't. It's much less people who were not thought to have ITP who then developed it. That's
per the McMaster study.
So what about your thought? Yeah.
Yeah. I mean, I think these numbers are probably not going to be as rosy in the vast majority of centers outside McMaster. I think there's going to be a lot more patients, both that were diagnosed with other things that actually have ITP and people who are diagnosed with ITP who actually have other things. And so I think we have to remember this, not just when we're diagnosing patients, but when we're following up patients. If someone is not responding to typical ITP therapies, even if we thought or they came to us with a diagnosis of ITP, we need to reevaluate that diagnosis. We need to never, put the blinders on and say, well, this patient was diagnosed with ITP in the past. They definitely have ITP. There's no biopsy to say somebody has ITP. It's a little bit more complex. So, people will sometimes ask, why don't we use platelet antibodies? I remember this from medical school. I remember this from fellowship. Why don't we use it? The reality is there's a high specificity of platelet autoantibodies for ITP, but there's not such a good sensitivity. Okay. And, when you have about a 50 to 60% average sensitivity, you tend to not have a really great utility of the test. The positive likelihood ratio is not so good that it really changes your post-test probability of having the disease such that it's really worth doing on a routine basis. Also, this testing is very challenging to do from just from a laboratory perspective. It takes a lot of blood and people who are thrombocytopenic and has a lot of nuances to it.
Hanny, before you go there, can I ask you two questions about it?
Sure.
Do you feel as you said, it's challenging? So if you're going to do it, you want to use a, quote, reference lab and not have the routine person, in your hospital do it?
Absolutely.
And the other question is, would you include glycoprotein 5 and would that help?
So the second question is definitely a platelet autoantibody 301 level question, not a 101 level question. But the short answer is The International Society for Thrombosis and Hemostasis has recommended that platelet autoantibody testing essentially always be done at a reference laboratory, a laboratory with a good amount of experience doing it. In the United States, for example, Versity is a good example of that. They do a lot of platelet autoantibody testing. You want to, send it in the right anticoagulant. You want to send the right volume of blood. There's a lot of aspects to how the test is collected and how the tubes are handled and such that matter. One of the recommendations is to include testing against both glycoprotein 2B3A and glycoprotein 1B9 at least. And when you do this testing, you asked about glycoprotein 5, Jim. There is evidence to suggest that adding glycoprotein 5 and possibly adding glycoprotein 4 as to the panel can increase the overall sensitivity. Probably not good enough, again, that it gets to where we need it to be on a general basis for use, but potentially more to come in that regard.
And sorry, I should have said this because it was a more platelet antibody 101 question. Are we talking about platelet-associated antibodies only?
Yeah, so we're not. We're talking about glycoprotein-specific antibodies that are on the surface of the platelet. So
right. Okay, that's what I meant.
When we talk about that, we call them direct. They're found on the surface of the platelet as opposed to indirect, which is found in the plasma.
Right, because plasma and serum, I think, are lousy unless you want to correct me, which you could.
No, they are lousy.
Okay,
they are lousy. It's the antibodies on the surface of the platelet, and that's very technically challenging to do and do it correctly to detect those antibodies on the platelet surface. Oh, so when we talk about the differential diagnosis for ITP, right, we can't forget, pretty much all the things on this slide, right? We don't want to be missing somebody who has platelet clumping, right? Platelet clumping can happen sometimes not, in response to being drawn in an EDTA tube and so-called purple or lavender top tube. And when that happens, the platelet count can be measured as very low, and sometimes it's not caught by the tech that there's clumping, or not caught by the automated software that there's clumping. So important to look at the peripheral blood film, important to look at the whole peripheral blood film, including the edges, and actually look at it under the microscope and not just rely on a program that takes a snapshot of it, because that's not going to show you all of the places where the platelet clumps might be hiding. In particularly older adults, right, we have to think of clonal hematopoiesis and clonal myeloid neoplasms like MDS. Patients with liver disease, typically don't have very, very low platelet counts, but certainly have platelet counts less than 100 chronically that we need to recognize. Of course, we talked about hereditary thrombocytopenias. Acute viral illnesses cause bone marrow suppression and can cause a short-lived platelet destructive process that we have to keep in mind. Hematologic malignancies, of course, we don't want to be missing. Drugs can cause thrombocytopenia, as we know. In pregnant patients with thrombocytopenia, right, the majority of it is gestational, but when it gets, consistently below 100 or particularly below 70, we start to worry much more about ITP. And then micronutrient deficiencies, usually present with more than just isolated thrombocytopenia, but we don't want to forget them.
Annie, could I ask you another question? What I wanted to know is, I'm not sure what the answer to this is, but I thought it's increasingly uncommon, or it's less and less common, that if you're the hematologist and you're seeing the patient, that you will be able to look at the smear in your area. And you made that point, which I thought was excellent, about computer and having like an image, that you can get sent. That sounds great, but so what is the story on that, do you think? Because that makes it harder also, because we always talk about looking at the smear because it's so important.
Yeah, I mean, you're definitely right that, the demands of clinical practice and schedules getting more and more, overfilled, and more separation from the clinic and than the lab sometimes makes, getting and looking at a peripheral blood smear challenging or difficult. It is still an essential part of evaluation and diagnosis of ITP. We want to make sure, we're not missing a thrombotic microangiopathy, for example. It's just really critical to look at that smear for a number of different reasons. And certainly, right, patients with congenital thrombocytopenias will often have very, enormous platelets as big or bigger than their red cells. And many times the platelets are all really large. In patients with ITP, there's some large ones, some less large ones. There are a lot of nuances to this, right? And it can be challenging logistically, but it's still definitely part of the recommendation. All right. So case 1, part 4, the patient is admitted for treatment of newly diagnosed ITP. When told he is to receive treatment, including corticosteroids, he becomes anxious as he states a prior 3-day methylprednisolone pulse given for a complication of his inflammatory bowel disease gave him anxiety and insomnia. So which of the following is the next best step in the management of this patient? Do we do a prednisone taper? Do we do a dexamethasone pulse for 2 to 3 cycles? Do we do IVIG? Or do we do a combination of steroid and IVIG, right? So this is a question, again, with more than one correct answer. And really, in truth, any of these are not particularly wrong. I think in this circumstance, right, the patient had developed anxiety and insomnia with higher dose steroids. So I might try to avoid dexamethasone in him just to minimize the acute side effects of steroids. And I might think of something more along the lines of prednisone. We could also consider, if it was really, really difficult for the patient, looking to IVIG. So when we look at the guidelines from the American Society of Hematology on treatment of patients, newly diagnosed patients with ITP, when the platelet count is less than 30, corticosteroids is generally recommended over observation in those who are asymptomatic or who have minor mucocutaneous bleeding, right? That 30,000 number is a number you'll see a lot in ITP guidelines. It's not universal for everyone. That 30,000 is a magic number, but it tends to be safe for most people when they're above 30,000 consistently. And when they're above 30,000, the guidelines generally recommend against corticosteroids and in favor of observation. In terms of admission to the hospital for a newly diagnosed patient, and again, this is a newly diagnosed patient, not necessarily a chronic patient with an exacerbation, 20,000 tends to be that number that we look at. In terms of the duration and type of corticosteroids, this is a very important take home. We don't want to be treating patients for longer than 6 weeks who have newly diagnosed ITP with steroids. We want to be transitioning them to another therapy if they need it, and tapering them off of prednisone and stopping after a total of 3 cycles of dexamethasone if we have chosen dexamethasone to treat them, because over treatment with steroids is a major problem. And if somebody needs treatment beyond this, they should be put on an alternative therapeutic. So IVIG is recommended when a more rapid increase in the platelet count is required. The patient has really clinically significant bleeding, or really problematic bleeding. The patient has a history of having really problematic bleeding with a low platelet count. It's reasonable to consider IVIG, or if, again, steroids are truly contraindicated. Anti-RHD immune globulin can be considered in people who are RHD positive and who still have a spleen. And that is often reached for when IVIG is in short supply or is contraindicated and the patient can't receive steroids, or if they need a fast improvement in their platelet count and can't get IVIG. Pregnant patients can receive either steroids or IVIG. So sometimes people are on team dexamethasone and sometimes people are on team prednisone. And the reality here is that the overall response rate, down the line is the same between these two drugs, meaning that, most adults with ITP will fail steroid treatment, or steroid treatment will fail them, I should say, within a few months, and they'll need a second-line therapy. Perhaps dexamethasone may work a little bit faster than prednisone. You might get 24 hours sooner increase in the platelet count. But again, keep in mind, right, the risk factors for acute steroid toxicity, which, are generally higher in a pulse dexamethasone situation than a corticosteroid taper with prednisone. So a nice meta-analysis from Mithwani and colleagues looked at prednisone versus dexamethasone in ITP, and again, did not find a significant difference in overall response rate at 6 months. IVIG, right? We use IVIG relatively frequently to treat patients with ITP who have an exacerbation, or sometimes newly diagnosed patients, particularly if we need that count higher. Don't forget about the possibility of side effects with IVIG. This is not a completely benign intervention, right? Patients can develop aseptic meningitis. It's common for them to develop headaches. They can develop VTE, and anaphylactoid reactions are possible in patients with IgA deficiency. So in those patients, it's important to use IgA depleted IVIG. And this is a Band-Aid, right? The response usually lasts for about a month. Anti-D, as I mentioned, this has very much like IVIG in a lot of ways. It doesn't work quite as fast. It does provoke a hemolytic anemia in most patients who receive it, that will lower their hemoglobin by a gram or two, and that's because we're diverting the immune system away from the platelets toward the red cells. And again, this is only useful if someone is RHD positive and if they have their spleen. So going back to case 1, the patient responds well to a 6-week prednisone taper as first-line therapy, but at routine follow-up 3 months after his initial diagnosis, his platelet count is 29,000. The remainder of the CBC remains unremarkable. He's not currently bleeding. He's not on antithrombotic therapy. He lives a sedentary lifestyle. He's very anxious about his platelet count and wants it to be normal again. How would you manage him now? So we could give him more steroids. We could give him more IVIG. We could start him on a second-line therapy like romiplastim. We could refer him for splenectomy, or we could just watch him. And I think this question really highlights the importance of minimizing toxicity in this disease, right? He's doing fine. Yeah, his platelet count's 1 below 30, but he's fine. He's not bleeding. He is, we don't need his platelet count to be normal. We don't need his platelet count to be about 50,000. We just need to take the best care of him that we can by balancing the risks and the benefits of therapy. And so if he was on antithrombotic therapy, if he had other risk factors for bleeding, right, then we might be more apt to reach for something and treat him. But in this circumstance, this guy would probably do the best just by watching him for right now. He might need treatment again in the future. We'll monitor him. But for right now, we can just observe. Corticosteroid overuse is really a major problem in ITP. So there have been a few studies looking at this. One cohort study of U.S. claims databases in adults with ITP showed that corticosteroids were the most common treatment option selected in each line of treatment, right? We want to be avoiding corticosteroid use except when absolutely needed to raise the platelet count above a dangerous place. And we want, especially in patients that are past that newly diagnosed stage, to be favoring use of thrombopoietin receptor agonists, rituximab, our second-line therapies, which my colleagues will talk more about. So going back to the case, he does well with observation and reassurance for the next 2 years, with his platelet counts ranging in the 25 to 40,000 range without therapy. At this time, he calls the office because he noticed some new, if minor, petechiae on his legs. He got over a case of bronchitis 2 weeks ago. He's found to have a platelet count of 15,000. All right, so what do we do? Now he's bleeding. His platelet count's lower, but very importantly, he's bleeding. So it's reasonable to treat this patient, but we don't need to treat him with corticosteroids right now. We certainly don't need to admit him. He has chronic disease at this point. We understand how his disease behaves. It's reasonable at this point to say, okay, let's consider a second-line therapy for your ITP.
Maybe we can stop for a minute. Any thought you have about that, what you've heard up to now?
I'm talking about case 1. If this patient really does have ulcerative colitis, as opposed to that's been in remission for like 18 years or whatever, that would be somebody you'd less want to do a splenectomy in because of the risk of sepsis if he gets GI lesions, just as an example.
Sure. Yeah, I agree.
And I think the other thing, when you talked about, so you decided on the prednisone rescue in the beginning, that's fine. Like you said, a lot of right answers. But if you're going to talk about rescuing him again, if his count goes down when you watch and wait him at 29, I think you'd have to have an idea with him about what you would do, because what would it then be? You know what I mean?
I think the question is, okay, you're at 29,000, how would you monitor him after that?
I'm happy with not treating him the way you
Yeah.
described it. I'm just saying you wouldn't want to give him another course of steroids if his count fell, I don't think, just as you said. So I think you
Yes.
would need to tell him how would it be handled if and when.
Yes, absolutely. Yes. At least what I do when I'm talking to a patient who has clearly progressed past first line, whether or not I'm treating them, I tell them that there are treatment options, and I tell them what those treatment options are. And so, generally speaking, we'll talk about what the various options are and what they might prefer, what might be the most optimal second line treatment for them. In that setting, we would definitely essentially preview what treatment they might receive to come if their platelet count were to get were to drop substantially lower.
And one more thing I'd just say, so I think that treating the inflammatory bowel disease is important too. So I think for these patients, getting on top of whatever disease it is that's associated, I think is really important.
Yeah, agreed.
Yep.
All right, let's go on to our second topic here, and Jim's going to start out talking about second and later line therapies. Jim?
So the case that was presented talks about what patients might need second line treatment. And as was discussed, in general, a platelet count of 30,000 or less would be an indication for second line treatment in somebody who's already had 6 weeks of steroids with or without IVIG and has a low count. And the platelet count might be different for a number of circumstances, as we also discussed, some of which are listed on this slide. So I'm trying to now focus on the next slide in what would be the choices. And we've heard about some of these, but primarily they would be splenectomy, rituximab, TPO agent, and fostamatinib, although there are other agents that have been used that I'm not going to consider here. As already mentioned, splenectomy probably would wait more than a year unless it was extremely difficult to treat the patient. They were having an ongoing, uncontrollable intracranial hemorrhage, or nothing you could do was bringing the count up. I'm a fan of the data that suggests rituximab is especially appropriate in a woman of childbearing age with ITP. Again, we're having all these that are people that need treatment, and ideally not too long from diagnosis. You would want to do appropriate vaccinations. And if you would consider splenectomy, if it failed, maybe you would try TPO agents already, and for whatever reason they were unsatisfactory, you would want to do the pre-splenectomy immunizations before you started the rituximab. Having said all that, I think great majority of patients currently would be getting a thrombopoietic agent. In the example that Hanny picked in the first case, he selected romoplastin, but there's also avatrombopag and there's also L-trombopag. And the latter two are oral agents. Especially L-trombopag has dietary issues. There's the least data with avatrombopag, but that appears to be a pretty effective agent. And Hanny has done a number of studies showing that patients not responding to one or the other agents, romoplastin and L-trombopag, could still do well with avatrombopag. So that might be the first choice, but in reality, any of the agents could be used if you were going to try them. You would want to start at an appropriate dose, 50 for L-trombopag, 20 a day for avatrombopag, and as Nichola pointed out, and it was on Hanny's slide, 3 mics per kilo of romoplastin for the, quote, typical patient where there's not some very special consideration. For fostamatinib, I believe the best evidence suggests that you would want to use it particularly in patients at high risk of thrombosis. It's worth pointing out that the original FIT1 and FIT2 studies showed a disappointing response rate, but more recent real-world studies in Europe and another, I believe, randomized study in Europe both suggested that the rate of real response might be higher. So it's probably somewhere in between, making it a better option. So initially, when the TPO agents were developed, a lot of people thought, well, they're going to work great, but my patient will be on them for life. So that's, why would I start them on them? However, they have the highest probably response rate of anything short of splenectomy and IVIG, or they're all in the same ballpark, well over 50%. And it seems clear that a significant fraction of patients can discontinue them within 1 year of use. There have been some very good studies that I think Nichola has been part of, one with romoplostin and one with L-Trombopag have suggested that if the patient responds to a platelet count over 100,000, they might well be more likely to be able to not only discontinue, but maintain an adequate count on no treatment at all for months. So that's obviously very good. The big question there is, well, what if you have your patient and their count shows a response, but the platelets are, say, 50,000? Would it be useful to give them a higher dose to get their count over 100,000, even though that's not the way we've been taught to practice, in order to make them better? And that gets at the issue of whether or not thrombopoietic agents are immunomodulatory. And originally, back with that first comment about initial thoughts, they were thought to be relatively inert. But it appears clear that they have immunomodulatory actions. Seems that they would all induce Tregs. They all might induce myeloid suppressor cells. Whether there's an advantage with romoplostin because it has an interaction with Fc receptors that the others do not remains to be seen. And they all do not have the same mechanism of action exactly, so there may be differences, but certainly there are possibilities there. We've talked about quality of life, and the, to me, slightly disappointing aspect is that bringing up the platelet count with a TPO agent doesn't automatically correct fatigue and other quality of life issues. It may make them better, but better is inconsistent and better may be limited in value. So what about inhibitors of SYK? Why use them in ITP? Well, it's very universally acknowledged that Fc receptors signal through SYK to initiate phagocytosis. And this is obviously important if you want to phagocytize IgG-coated platelets, as we believe is the primary means of platelet destruction. So inhibiting that should mean that even if the platelets have antibody on them, they'll continue to circulate. And this is consistent as a hypothesis with the fact that the platelet count may go up within 1 to 2 weeks in many of the patients. Important also to realize that fostamatinib is not thought to be a highly specific to SYK tyrosine kinase inhibitor, and that may or may not be why there are side effects that are also seen that are more widespread than might be considered, and we'll get to those in a minute. It's also worth commenting about that BTK signals downstream from SYK, and that's interesting because it may also not be prothrombotic. I didn't put a slide in about the thrombosis issue, but the thought is that an inhibitor of SYK, and for that matter of BTK, may inhibit platelet activation via GP6, CLEC2, and the platelet FC receptor, but not through the more conventional areas in which we think platelets are activated for thrombosis, so that this may be able to inhibit thrombosis without creating bleeding. So FIT1 and FIT2 were parallel identical studies. I think these were published in 2018 or 2019. They're both 24 weeks. They both started with the same dose. Two things to realize about these is that these were the first studies where, in the case of FIT1 and 2, 49% of the patients had failed a TPO agent, and the average duration of ITP was over 8 years. So this was much more refractory than that of previous studies, although, to be fair, one of the two key studies for romoplastin required having failed splenectomy, and no other study since then that I'm aware of has done that. Primary endpoint was being assessed on platelet counts obtained biweekly, and it was to be greater than 50,000 on 4 of the last 6 weeks. And an overall response, unlike the primary endpoint, was just to have one count over 50,000 in the first 12 weeks. So primary response was achieved in 17% of FOSTA patients. There's a little bit of a debate about whether one of the patients did or didn't respond, which is why it's between 18% and 17%, and was only seen in one placebo patient who was thought post hoc to possibly have cyclic thrombocytopenia instead of true ITP. The overall response rate was 43% in FOSTA and 17% in placebo. We talked about how bad the patients were. Almost all the patients increased their dose to 150 milligrams twice a week. And the side effects for FOSTA were predominantly GI and also the induction of hypertension. And probably as higher a percentage of these patients had side effects that were bothersome to patients, at least, than those seen with other patients. Of note, in the open label extension, over time, patients did better and better. And relative to why antithrombotic, in I think it was 182 weeks of fostamatinib, there was only one TIA and no thromboembolic event, either arterial or venous, that occurred. And that's very different from what's been seen in ITP with other agents, although TPO agents appear to be worse than other agents.
So just a question. So, given that so many people started on fostamatinib need to go up to 150, almost everyone, I don't think I've ever treated a patient that I haven't up titrated to 150. And that there's a lot of, I think premature discontinuation of fostamatinib after someone's on 100 for a month and they don't respond. If you could do this again, Jim, if you could redesign this, would you make the starting dose 150? Or are you worried about the acclimation and the toxicity enough that you think it's important to have that 100 BID for a month?
I'd also be curious on what Nichola thinks, but I think if you wanted a higher response rate, that would be the optimal way to do it. And in the study we published back in 2009, we even went up to 175 milligrams, and in other indications, people have gone up to 300 milligrams twice a day. So I'm not sure. I think what does seem clear is that the side effects increase as the dose increases.
Yeah.
What do you think, Nichola?
I think I like the 100 milligrams twice a day. I think there's less side effects to it. I find fostamatinib a very curious drug. You can either respond brilliantly to it at low doses or have no response at all, and you either tolerate it completely well with no problems whatsoever, or you get horrific diarrhea. And I have seen infections, so higher infections. So I like the lower dose, and combination as well, using fostamatinib in combination of avatrombopag allows me to use a lower dose. So yeah, I think we're all having very different experiences. If you read the Spanish data, there's no side effects whatsoever to fostamatinib, and 70% of people respond. So I wonder whether that's a vitamin D effect. We don't have that response rates in the UK. So
I've never met a patient that I've treated with fostamatinib who hasn't developed hypertension, diarrhea, or both.
Yeah. Oh,
So.
Totally. So that's the lower doses. I think about if you respond to a low dose and use it with avatrombopag as well, I think it's great. But higher doses, I don't have anyone on higher doses that doesn't have something. Going to the toilet 11 times a day. So.
Yeah, I agree that the hypertension, I think at least some amount of points in your blood pressure is almost universal.
Yeah.
Let's move on to the next topic.
Okay. So FcRn inhibition has been a very interesting approach to therapeutics of autoimmune diseases. FcRn recycles IgG. If you did not have FcRn at all, your IgG levels would be much lower because the half-life would be 1/5 as long. So theoretically, it should be a brilliant treatment because it'll lower your IgG. It'll correspondingly lower your IgG autoantibody, and disease should improve. Myasthenia gravis has had two different agents work in it. And when you look at the two phase 3 studies, the overall IgG, the anti-acetylcholinesterase antibody, and two different quality of life scales all move in lockstep, meaning when you lower the IgG and you lower the autoantibody, quality of life gets better in two different scales. And then as the effect wears off, the quality of life goes back and the IgG autoantibody level goes up. So should be brilliant in ITP. P.S. It's not. The phase 2 study with efgartigimod had a not great response, and I don't think I need to go through all the details, but I'm happy to if there's a reason to. The rozanolixizumab phase 2 study had great results at the highest dose, the 20 mg per kg single infusion, and even the 15 mg per kg single infusion, but had more side effects at that dose, precluding its use, so that the use in their clinical trials, that's been published, 10 mg per kilo, but the studies were aborted for complicated reasons not having to do with side effects. So the phase 3 of efgartigimod, phase 3 intravenous, published in the Lancet in I think very late 2022, had a 22% primary endpoint of durable, multiple response levels compared to 5% in placebo. And the international working group endpoint that included not bleeding, counts greater than 30, more than double baseline at least twice, was met by 50%. So it seemed to be reasonable. In general, there have been relatively few infections noted despite the IgG reductions of 60 to 70%, presumably because the rest of the immune system is left unaffected. However, when the phase 3 subcutaneous study was done, the placebo rate was higher than the active drug efgartigimod response. Thus far, that's available only as a press release. So I think overall, it's clear that treating ITP with FcRn inhibitors is not quite as simple as might be seen in other autoimmune diseases. And for example, another autoimmune disease where it was thought that this would be great was in pemphigus, where it didn't work out very nicely, very cleanly. One of the agents, I think efgartigimod, has been approved for chronic inflammatory demyelinating polyneuropathy, but it just seems that, like we would surmise in rheumatologic diseases, the antibodies may sometimes be a marker of the disease, but not automatically the prime mover.
Let's go through your cases, and maybe for each one, we can just ask the other two faculty members to comment after you present it.
Fine. So this is a patient who was in the very original romoplastin study. At the time, he was 39 years old, maybe even a little younger, had been on prednisone for years. In 1982, we gave him IVIG. He was the 7th patient I ever treated with IVIG. Then he continued maintenance for several years, but he continued to need infusions fairly frequently, every 2 to 3 weeks, and that was a tough way to go. Tried azathioprine, tried cyclophosphamide, even tried an experimental ricin-conjugated anti-CD5. None of this worked. So he proceeded to splenectomy, and that and rituximab both had minor responses, but again, not great ones. They were short-lived and they didn't work for him, and his count was very low. So then in 2002, when the romoplastin study was initiated, he was in the initial group of 16. He responded reasonably well, went on the open label study, and was on that for many years, requiring a dose of 12 mics per kilo. And just to remind you, the initial maximum was 30 and then 15. And it's only now that subsequently that the maximum dose was reduced. So over several years, we were able to taper his romoplastin to about 7 mics per kilo, but we couldn't get his dose below that. So we thought he could transition to avatrombopag to make it at least easier so we could just take it by mouth. And that didn't work well for him. And when we tried romoplastin again, that didn't work well either, and we couldn't go above 10 mics per kilo. Throughout this, he had bone marrow examinations that were pretty consistent, and now he's trying another experimental therapy, and we'll see how that goes.
So, Hanny, any comments on this case?
Yeah, Jim, really interesting case in presenting one of the first patients that was treated with romiplastim. Why do you think he, when you transitioned him to avatrombopag, you said he responded for a while, but then stopped responding to the AVA and then wouldn't respond to romiplastim when you put him back on it? So do you think his disease, quote unquote, progressed such that just TPORAs were no longer really effective at that point? Do you think that switching him to avatrombopag had a deleterious effect and that you should have just stayed the course on romiplastim?
Well, in retrospect, I definitely think in hindsight, it would have been better to just stay on romiplastim. But I think his disease progressed in ways that I don't really understand. I think, Nichola, you have the much better understanding of all the subtleties of that than I do.
Yeah, I think that some people have an autoimmune disease that we're not making better from it. And I think the TPOs are great for a lot of people, but I think for some, we've seen this too. And actually curious, which I can't understand, the switching to AVA and then getting more bleeding symptoms, so back to romoplastin, but respond worse. But I think for some, they do get worse. And particularly, this patient's had ITP for a huge length of time, haven't they? So we're not treating them. And I think we're not quite sure why.
Most of the patients from that original study that were from our site, which was about 13, tended over 10 years, let's say, to get better over time. So he was unusual in that he didn't. Yeah. And I think, though I don't know this, if I could have given him, say, 12 mics per kilo or something when I restarted, maybe he would have then responded. But I think there is progression. Nichola, you've done the work with T-cell clones and cytotoxic ones. I think it's clear that patients who've had ITP for, say, 10 years, that was a predictive factor for not responding to rituximab or anti-CD40 ligand. I think some of them get worse. Their disease gets much more complicated and somehow ingrained.
Yeah, no, I agree.
I think it's important that we point out that typically, right, when you switch from one TPO to another, it's totally fine. In other words, if they don't respond to that other one, you can switch them back. This is unusual in that, the patient developed that. Yeah.
So I want to move on to Nicola's presentation in a second, but let's just hear about this 51-year-old woman. What happened with her?
She seemed to have an underlying autoimmune phenotype in that she had Hashimoto's and irritable bowel, and eventually she had an ANA greater than 1 to 2,000. More or less across her history, she responded to IVIG, but little else. So if you look at the third paragraph from the bottom, she tried anti-D, she tried danazol, azathioprine, she failed splenectomy, tried Vinca, had been on rituximab, and this is a long time ago, had clinical trials of anti-CD40 ligand and then a TPO agonist, and she never entered remission or really could maintain adequate counts and was dependent on monthly IVIG. So then she started on fostamatinib, and basically she's still on it from 2007 to the current day. She has been able to reduce her dose finally very slowly. Initially, we tried to taper it a little, as you can see in the 2 times where the platelet count in blue falls. And when we did that, her count fell, and that was like a major crisis for her. So we didn't try to taper again for a long time. And then, like I say, she's tapered down to every other day at a lower dose now. And part of the reason I wouldn't want to stop her, I don't personally take care of her at the moment, is because her ANA is so high. I believe she has this strong underlying phenotype, and that may or may not have contributed to why she responded. So she's not on a very big dose. She's not having a lot of really any side effects currently that I'm aware of.
Nichola, any questions or thoughts about this case?
Yeah, I think I have a similar case to discuss. I think the fostamatinib can be really good, actually, but the problem is that the side effects. So we've had to stop it because of infections, because of inflammatory bowel disease. But curiously, I think probably a bit like your patient too, some of our patients carry on despite the side effects because they've had such a good platelet count. So it's good, but not quite good enough. And I think this infections, I think, is coming too.
This is a great example, right, of a case, right, where the fostamatinib was a miracle drug in improving the platelet count after everything else failed. But even still, right, a breast abscess, IBS might be worse. Who knows how much of that might be related to the FOSTA. I mean, probably, we don't know. We can't say, but yeah.
All right. Well, that sort of is a good lead into the final topic we have here, which is tolerability. We've alluded to a number of these things, but we wanted to get into more depth. So, Nichola, let's talk about this issue.
Okay. One of the things you asked me to do is just talk about some of the advantages and disadvantages of different treatments. And splenectomy actually has huge amounts of advantages. We don't do splenectomy very much anymore. It's hardly done at all in the UK now. But actually, it does have a 60 to 70% response rate. For those patients, there is a treatment-free remission. There's no ongoing need for monitoring for hospital attendance. And actually, I think it would be good for us to do a survey of patients who've had their spleen out, they've had a good response, and are they depressed? Are they still fatigued? Because, they're not seeing us anymore. So I think it is a really good treatment still, actually, even though we're trying to avoid it. And certainly I have a child who we took the spleen out of, and he's celebrating his 5th year now post-splenectomy, and he had a really hard time before. I think there's the obvious concerns around splenectomy, and one of the big problems is because we don't know who's going to respond to it. And if you don't respond, I think there's a lot of negative psychological, emotional welfare for people too. There is increased infections. You can get overwhelming sepsis, although that should be easy to manage. And there is this concern of increasing thrombosis, and particularly the French show this increased cardiovascular risk in patients. But can we be better at managing that? So antibiotics, vaccines, ensure the correct diagnosis. Maybe some of the overwhelming sepsis is related to common variable immunodeficiency or a lupus or something else that was missed. Prompt treatment for antibiotics if you're unwell. And I think perhaps patients go off and we forget about that. And review of other cardiovascular risk factors, blood pressure, cholesterol, and things like that. Can we make splenectomy actually better? So I think it's important we don't forget about that. Certainly it's not advocated with us anymore. So I don't know about what's happening in the US about splenectomy. Is that kind of, we mustn't do it anymore?
Well, I wouldn't say mustn't do it. I would say not in the first year. It's just fallen out of favor because people, obviously in many cases prefer medical treatments to surgical ones. I do think it's important in terms of the success rate, right? You mentioned the 60 to 70%. There was a study published from the French group just a couple of years ago, people who have failed TPO-RAs and rituximab, right? Their success rate was about 46%. So I do think that, at least when we now are used as frequently as we were before earlier lines, I try to be careful about using, about giving a number that might be a little bit too rosy in patients that have failed multiple therapies.
But 40% is higher than the fostamatinib response rates.
Yeah, it is.
It's true. Thought.
It's
and
true.
Higher than rilzabrutinib response rates.
We've been working forever on a medical decision analysis, and the bottom line is that if you would switch from one treatment to another if it didn't work, I think we underutilize splenectomy, though there's lots of caveats to that, as you were both pointing out.
Okay, next one, rituximab. Okay, so this is an example of a patient that I've looked after who got rituximab in 2013. She was aged 15. It was before TPOs were available for children. And she had a great response rate. So she's 15 years old. She's had a complete response for 2 or 3 years. She's got through her major exams. She got to university. She relapsed in her first year at university. We gave her rituximab again. She had a complete response again for 3 years, didn't need anything during college, sort of university. Relapsed again at the end of that. We gave her rituximab again. And she was able to travel, go to China, have a normal life. She's now in a stable job. She's not had any increased infections and remains in CR. So, this young adult has done great on rituximab, and she's not had to have regular blood tests. She's not had to take regular tablets, not had to have lots of injections. So she's gone through all of her college life kind of disease-free, really. So I think, again, for some people, I think this is a great treatment, really. Again, I think the problem with this response rate of 50%, Jim talked about the fact that perhaps young women earlier on in their diagnosis might be better response rates. The advantages are the long treatment-free responses in people if they do respond. And even 20% of responders have this long-term remission greater than 5 years. A lot of Jim's work sort of shows that. And if you do relapse, most people will respond to retreatment. So what about the disadvantages? So most people will relapse afterwards. And there are rare infections. PML, I think, is rarely reported in ITP. It's more on the lymphoma population or lupus. Reactivation of hepatitis B, we now treat that to stop reactivation. I've not seen it in an ITP person. Hypergammaglobulinemia is rare in ITP as long as you've made the diagnosis properly. So we certainly look at immunoglobulin levels before we give rituximab. There is this 2 to 5% incidence of hypergamma after lymphoma or lupus with repeated doses, but you can give IVIG replacement therapy if needed. And maybe there's this reduced response to vaccines. And certainly during COVID, there was an anxiety that you might have worse COVID. And from the lupus or rheumatology literature, it suggested that you might get a worse COVID if you're on rituximab. But we certainly didn't see that in our cohort of patients, or that maybe that we're using rituximab in a younger cohort that may not have got COVID anyway. How to manage that? Consider revaccination, check immunoglobulins, hepatitis B status before and after treatment with rituximab.
I think Walid is going to have some data suggesting maintenance may have a role, as it does in, I think, lymphoma. And we published a paper that was 16 case reports suggesting it had a role as well.
Yeah, and we certainly did that through COVID as well. We kept people on rituximab regularly, actually, to keep them out of hospital. And I think that for people not having relapses, having normal platelet counts does manage their ITP-related anxieties. And I think one of the things I've seen in my cohort of patients is that actually when patients are referred to me with refractory ITP, they've never had rituximab. So, I think that there is, certainly in the UK, we're going away from immunosuppression. So while TPOs are great in lots and lots of patients and you can come off it, I think there is a role for immunosuppression. Okay, so the other drug to talk about is eltrombopag, and this is an example of one of my patients who started on eltrombopag at the age of 17. He is now on eltrombopag 50 milligrams 3 times a week. He's got reduced bleeding, nosebleeds, improved schooling. He was not at school quite a lot during the first year of his ITP, and reduced bullying. So this is just your platelet count over time, showing at the beginning, before he started eltrombopag, occasionally needing steroids or IVIG treatment, and then a sort of fluctuating course that you often see on TPO receptor agonists, but starts to stabilize over time. And we've talked quite a bit about TPO receptor agonists. You've got 3 different agents: eltrombopag, avatrombopag, and romoplostim, acting at slightly different parts of the TPO thrombopoietin receptor. Romoplostim at the thrombopoietin receptor, eltrombopag and avatrombopag are small molecules activating in different places, probably causing a slightly different downstream signaling, and with maybe one of the good rationales for trying one, and if you don't respond to one, you might respond to another. And we have used combined treatments, certainly avatrombopag and romoplostim together as well. Advantages: 50 to 60% response rates, well tolerated, no impact on vaccines, daily tablets or weekly injections, and reduced bleeding in clinical trials. And some patients can come off treatment, as Jim alluded to, the sustained response off treatment in clinical trials as well as in clinical practice. Interestingly, I was just chatting to one of my pediatric colleagues a couple of weeks ago, saying that perhaps in children we find less patients coming off TPO receptor agonists. That's just sort of a feeling of an experience for that. Disadvantages: so eltrombopag is an ion chelator, combined to food, so it's not absorbed. And there's food restrictions, and I think the food restrictions can be really problematic for people. It's very problematic for teenagers. They usually lose their response to eltrombopag during their holidays because they don't wake up till 1 o'clock in the afternoon. Whether it also then causes some iron deficiency and tiredness as well, I think it's hard to read that literature, but certainly I think that is an issue. Liver function abnormalities, which I've seen more in children than in adults, but I think the food restrictions is more of a problem than we discuss. Fluctuating counts is an issue, and that creates a lot of anxiety. And for some people, it's not possible to continue them just on solely TPO receptor agonists because of the thrombosis. 6% incidence of thrombosis in clinical trials. As Jim said, I think it's not entirely clear we're improving their fatigue or quality of life. All of those tools were not routinely assessed, and the fatigue, I think, is much less clear in the TPO receptor agonists. And for some, they're now on long-term treatment. So I do have patients who've been on it for 10 years. Could we have got them off it? Could we have put them into long-term remission with splenectomy, rituximab, something else? I don't know. And I think lots of people can go to 3 monthly full blood counts eventually, but I think it can interfere with their lives at the beginning when you're starting to give them treatments.
Before you go on, you go on, I just want to go back to this a little bit. So, Hanny, can you talk a little bit about choice of TPORA agent and also a little bit more granularity about food and L-Trombopag and sort of any clinical pearls you have?
Yeah. So, when I have a discussion with my patient about starting a thrombopoietin receptor agonist, I always try to I discuss the pros and cons of each agent, right? We have Remiplastim, which is a subcutaneous injection in the US. It's given in the clinic once a week. That's not the most convenient thing, but there are some patients that have more challenging disease or who have a lot of anxiety around their platelet count who really want to know what their platelet count is every single week. And for them, it's actually perhaps even more optimal to come in and check. And then there's L-Trombopag and Avatrombopag are oral drugs. L-Trombopag is, as Nikki alluded to, because of dietary restrictions, it can be challenging for some patients. Almost anyone can say, I'll adhere to a certain restriction around taking the medication for a period of time, but it's often difficult to maintain that for years and years and years, as is often required in terms of treatment. The dietary restrictions in particular are for divalent cations, so calcium and magnesium, foods that have enough calcium and magnesium in them, which is not really that much calcium and magnesium, in order to significantly reduce the absorption of the L-Trombopag. So, I don't know about you, Neil, but I don't know how much calcium and magnesium in most foods. I doubt many of our patients do, right? So I think it's what I tend to tell people is, ideally it's kind of a 4-hour, sometimes ideally up to 6-hour, almost fasting window around taking it. So, 2 to 3 hours before and 2 to 3 hours after taking the pill, avoiding essentially much eating at all. That's good for some people. People intermittent fast, it's great, right? That's totally fine for them. A lot of folks, have a routine where they always are waking up early in the morning and they can take their L-Trombopag first thing when they wake up. It's good for them. But for some folks that have a more typical, eating habits and snack a lot, it's not the easiest thing to do. And then
like teenagers,
exactly.
Just snack
and then
all the way through the day.
yeah, some people they don't even have meals. They just eat snacks. They graze. L-Trombopag is a nightmare in that population. It's not ideal. And then Avatrombopag, right, is our newer drug. And as Jim alluded to before, it does not have as much data as the rest of the other two agents do, in terms of the length of treatment. And, we do get asked sometimes, right, what are the long-term side effects of using a drug like this for 10 years, 15 years? We extrapolate from L-Trombopag and Remiplastim data, and we assume that Avatrombopag is a similar safety profile on that basis. We don't actually have that information yet. Avatrombopag is convenient in that it's oral and it doesn't have the dietary restrictions, and you don't have to monitor LFTs. But like I said, it doesn't have that body of data at nearly as much behind it.
I think it's a much easier drug to use, isn't it? I think.
I agree. Yeah.
Probably stronger too.
Yeah.
I was curious, Nichola and Jim, if you want to add anything to what Hanny just said, Nichola?
Yeah, really important to ask patients what time of day they take their L-Trombopag, because if they're not taking it last thing at night or first thing in the morning, they're not taking it properly. And you can ask them if they're complying to food restrictions, and I think you can't tell that until you're actually asking exactly when they're taking it. And I think the other thing that I've noticed as well, sometimes someone starts iron and doesn't really think about the fact that actually the iron you should avoid too. So you really have to properly ask them about how they're taking it, especially someone who suddenly loses a response.
Jim, anything you want to add to that? I remember, Hanny, you told me that a lot of people get up in the middle of the night, go to the bathroom, et cetera, that maybe that's a pretty good strategy. Jim?
Yeah, correct. It's great for people with BPH.
I was just going to say that, and I made that suggestion at a meeting when somebody who's even older than I am asked about it, and I said, "Well, when you and I get up in the middle of the night, we could take it then." And I got hammered by him for that. But yeah, that's the funny. Ultimate. The other thing I would say is, I had a patient who was taking it first thing in the morning. but then they would have coffee, and they didn't think they were having milk when they just put a little milk in the coffee or tea, and boom, that seemed to do it. So
yeah, and I think particularly the teenagers, they have such an erratic lifestyle anyway, that trying to take something at exactly the same time each day and remember food and things like that, I think it's really tough. Avatrombopag is much easier for them, I think, and actually weekly injections is much better for them too, so they don't have to think about it. So yeah.
And right now, avatrombopag is not yet approved for people under 18 in the U.S., but there was an EHA plenary last year presented by our colleague Rachel Grace, who showed that that it is successful in treatment of pediatric ITP as well. But so hopefully another option for them eventually.
So let's finish out, Nicola, with fostamatinib.
So, and this is an example of a patient who says she was diagnosed with ITP 2010, refractory to rituximab, mycophenolate, danazol, thrombopoietin receptor agonists, only romiplastim and L-trombopag at that time. AVA was not available. And she was referred to me for the clinical trial of fostamatinib. And before she was started on this, she was on weekly IVIG and steroids and really had no life whatsoever. And she had a slow response to fostamatinib. It wasn't certain she was going to have this response really, but she did have a good response to fostamatinib. She had increase in chest infection. She's now on prophylactic antibiotics. She had increase in blood pressure. She is now on antihypertensive treatments, but she was ecstatic after 2 years of being on fostamatinib that she's now able to go on holiday. So, this is an example of a patient whose ITP really, really limited their life. And she doesn't mind a bit of high blood pressure. It was well controlled. She didn't mind the infections either. The ITP was really limiting her life. So this is her platelet count. And she's now on so this is almost 10 years of fostamatinib, and she's now on 50 milligrams 3 times a week. So she's someone we've been able to slowly reduce her fostamatinib. Jim, you've already talked about fostamatinib, why it's useful, and I think you have potentially 3 parts that it can work on: your proliferating B cells, your stopping your macrophage-mediated destruction. And I do think the SIK and the BTK, the first really targeted treatments for how, the pathogenesis and ITP. And I guess somewhere between 20 and 50% response rates in refractory disease, but certainly the Spanish data suggests and the ad hoc data from the fostamatinib clinical trial suggests you may get better responses early on if you're giving it within the first year of disease, and maybe before you get T-cell mediated disease, maybe before it evolves into something more complicated. So I think it's really interesting. It will be exciting to explore that. And actually combining it with avatrombopag has had really nice successes. And as Jim pointed out, there were no thrombotic episodes in the clinical trials, which is very different from the 6% thrombosis that occurs in all of the TPO receptor agonists at clinical trials. But it does come with its problems, and we have seen increased infections. There was increased infections in the clinical trial, although ITP patients also have increased infections. And the gastric side effects can be hugely problematic. You can manage it with loperamide, but for some patients, they cannot tolerate it, and it's the worst thing that's happened to them in their ITP journey. High blood pressure, again, can be managed with medication. I guess we need to know whether there's any long-term issues with causing high blood pressure. Liver function abnormalities also a problem. So monitoring blood pressure and liver function tests is really important. And I think that's a really, really important point. It's not something we're always very good at. I think as hematologists, we do need to make sure you monitor the blood pressure in these patients. I think that's a huge problem, huge issue that we need to remember to do, is measuring sort of blood pressure. And then you asked me also to talk about some of the promising new medications, and I think certainly rilzabrutinib, BTK inhibition, sat downstream from the SIK inhibitor, looks very promising. Response rates somewhere between 30 and 40%. The phase 3 clinical trial was positive, but again suggesting durable responses maybe 20 to 30%. But I think one of the really exciting points for this is the improved fatigue. So the rilzabrutinib for the first time really showed that patients felt better, their fatigue was improved. And I think some of the patients that we had on the clinical trial also felt clinically better, even if their platelet count doesn't come up. So I think that's exciting. And there are gastric side effects, and I think perhaps the response rates are limited in the chronic refractory patients. So I think we need to see if you get better responses early on in disease. And here's my final slide of all the other promising treatments in clinical trial. And I guess the thing is, I just point out from this is the majority of the clinical trials target B cells, target more parts of the B cells, the pre-B cells, the post-B cells, the late B cells, the plasma cells, but we're not really targeting the T cells, which is one of the areas we've sort of tried to look at.
So I want to go back to Hanny in a second and ask for his thoughts about some of these new strategies. But just getting back to rilzabrutinib, Nichola, can you talk a little bit about why it's different than other BTK inhibitors out there, ibrutinib, acalabrutinib, et cetera, and particularly the issue of platelet dysfunction?
Yeah, sure. So I guess the first concern was that some of the first BTK inhibitors had bleeding episodes, particularly in the CLL patients, and often in the CLL patients who were also on aspirin. So these are an older population, and BTK is important, and SYK is important, and platelet activation and platelet regulation. So the concern was that the BTK inhibitors might prevent platelet aggregation and thrombosis and cause bleeding, particularly in thrombocytopenic patients. I think rilzabrutinib is different from the first BTK inhibitors. There is some data that it doesn't inhibit platelet aggregation even in healthy individuals. It does have a much smaller target, and Hanny will go into more details. I'm going to pass that on to you about exactly where it binds and doesn't bind. But clinically, we did not see increase in bleeding, and we certainly have not seen an increase in bleeding in these patients. So it may or may not work differently on the BTK and the platelets. I think the other thing that we have not fully explored is what platelets are doing in ITP. So actually, it may stabilize a platelet in patients with ITP. So the BTK pathway, I think, is not fully understood in ITP. So I'll leave it at that.
Neil, could I just say one thing before you ask Hanny for his comment?
Sure.
We didn't mention two things about FOSTA that unfortunately I think are important. It's not going to be approved in kids less than, say, 16 because of the apparent effects on cartilage. And it's contraindicated if you're trying to be pregnant. And we had a patient who didn't tell us she was trying to be pregnant and then miscarried. So I think those are two important limitations we have to include. Sorry.
No, that's good.
No, that's really that's really great input. Hanny, any thoughts about rilzabrutinib and also this incredible diagram? I see anti-CD38 on there too. I'm curious about that and a lot of other pathways. Any comments?
Yeah. Rilzabrutinib, I think, is definitely a promising agent in ITP. I agree with Nikki's comments. I think the fact that it showed a clear improvement in fatigue is really something, and something that maybe the mechanism of this drug is reducing that inflammation that we think might be causing fatigue or contributing to fatigue in ITP. Interestingly, right, in that study, the people who responded with a platelet count response had the best improvement in fatigue, but the people who didn't respond still had a clear improvement in fatigue, and the people who received placebo, their fatigue actually got worse. Right. So it was really interesting that you saw that improvement in fatigue, even in spite of the platelet count not responding. So that's rilzabrutinib. In terms of some of these other agents, I mean, we have some really potentially promising drugs. So you mentioned anti-CD38 antibodies. So, right, these are a mainstay of therapy in plasma cell neoplasms. And in ITP, there is an investigator-initiated study of daratumumab that's completed, and we're just waiting for the final results to come. But there is also other therapeutics like mezagitamab which is also called TACO-79. Mezagitamab that was presented, the phase 2 study in 41 patients with ITP, was presented at ISTH 2024. And that was very intriguing drug. Patients were reasonably heavily pretreated, but still had 80 to 90% response rates to mezagitamab in terms of the potential for platelet improvement being very good, even though they were relatively heavily pretreated. So, that might be a new episodic therapy, right, that we would use, because you use 8 subcutaneous injections. Then that study, they use 8 subcutaneous injections and stopped. There was a phase 3 study that's ongoing. This might be a perhaps better rituximab in terms of an episodic therapy that people respond to faster. We don't know. And then CM313 is another anti-CD38 antibody being developed out of China. There was a New England Journal of Medicine publication with 22 patients with ITP receiving it. Also very high response rates. Patients in that study were only followed out to 6 months. And so, one of the questions with anti-CD38s is you get these really great response rates. How long does it really last? And so I think that's really the question that remains to be seen for any of them. But CM313, another drug, in that study, the New England Journal paper, it was infusional rather than subcutaneous. But these drugs, in theory, can all be subcutaneous, and so potentially another good option. In terms of the anti-BAFF receptor inhibition, so B-cell activating factor, BAFF, also called BLyS. We have a BLyS antibody or anti-BAFF antibody that's used in lupus called belimumab. But there is one that's being developed now in multiple autoimmune diseases that is an anti-BAFF receptor antibody called ianalumab. And there was some data already published on this drug in Sjogren's syndrome. It's in development for a number of things. The largest ITP development program ever is actually that it's simultaneous is with this drug. There's 2 pivotal phase 3 studies looking at first and second line ITP, trying to modify the disease course, really change that paradigm. As Nikki suggested, maybe with something like rozibrutinib, you might be able to modify the disease course before people develop all these T-cell clones. That's the goal with these ianalumab studies, these big pivotal ianalumab studies called VAHIT-1 and VAHIT-2. And so, the data from those studies is really anticipated. And this is just 4 infusions every 4 weeks, in addition to either corticosteroids in first-line patients or L-Traumapag in second-line patients in those clinical trials.
This concludes our program. Special thanks to the faculty, and thank you for listening. This is Dr. Neil Love for Striving for Consensus, Current and Future Management of Immune Thrombocytopenia.